Menopause and mental wellbeing. Webinar recording hosted by the Alliance and Scottish Government.
Good morning, everyone. For anyone who doesn't know me, my name's Irene Oldfather. I'm Director here at the Health and Social Care Alliance. I'm delighted to be convening this seminar in conjunction with our partners at Scottish Government. We work very closely with the Women's Health Plan team, and this is part of our ongoing work around sharing information. As many of you will know, the 18th of October, I think it was World Menopause Day. And so we decided that we would try to put together a session on, I'll say a little bit more about our objectives for today in just a minute, but that we would try to put together a session that would allow people to have a little bit of information and ask questions. I mean, I think increasingly we get more and more information around things like menopause, but women still many women still have questions and things that they would like to know a little bit more about. So hopefully today we can address that. Can I maybe just say a few words about people on the screen? So we're joined by Karen and Jackie, our BSL language interpreters, which means that you can access captions on the screen as well. And also we've got Jen from my team and the Women's Health Plan joining us, and she's done all the hard work behind the scenes on this. And also we're joined today by Dr. Katie Marwick and Dr. Becky Howie, and we'll hear more from them in just a few moments. And Claire Mills, our graphic designer, and Claire's been a regular to our sessions and always produces this most amazing graphic output, which really enhances, I think, the story that we tell around the sessions. So thanks, Claire, for joining us today as well. So today we wanted to focus a little bit on menopause and mental health. I mean, I think as many of you know who've been joining our webinars over the last year or two, that we've focused a lot on physical symptoms, things like hot flushes, and of course very obvious signs of menopause. But from speaking to women, we thought that sometimes there can be changes to mental well-being, and we thought that this might be an appropriate topic for us to discuss in this month of Menopause Month. And that's clearly borne out by the number of people that are joining the session. So this today is the focus of attention. And I'm very pleased to introduce Dr. Katie Marwick. Dr. Marwick is an academic psychiatrist specialising in reproductive psychiatry. She's currently Senior Clinical Research Fellow at the University of Edinburgh and Honorary Consultant Psychiatrist at NHS Lothian. So we're very, very pleased to have you today, Dr. Marwick, and we look forward to hearing about how the menopause can impact mental well-being. So thank you for that, and over to you.
Right, okay. So I hope everyone can see my slides and hear me okay. Jump in if you can't. So yes, my name is Katie Marwick. I'm a psychiatrist and a researcher. I have a PhD in neuroscience, and my primary employer is the University of Edinburgh. But I'm also a clinician specialising in women's mental health, one of only a handful of psychiatrists in the UK working in this area. And that means that I work in the premenstrual syndrome clinic in NHS Lothian and also do some perinatal psychiatry. My research interest is about the neuroscience around menopause, and that's what I hope to share some of with you today. So a few introductory remarks. I'm going to be using the term women to refer to females throughout this talk, but I want to extend a warm welcome to everybody, whatever gender or sex, who's on the call. I like to be evidence-based and talking about the science, so I'm going to give a little bit of detail about the scientific publications that underpin what I'm showing to you, with the first author's surname and the year and the journal, which means that if you want, you should be able to look it up yourself afterwards to get a bit more information. And I don't have any conflicts of interest. So, a few basics. I expect you're all aware that menopause is when periods permanently stop, and that's because reproductive function in the ovary stops as well. What this chart shows are hormone levels on average plotted against years before or after the final menstrual period. So you can see the year of the final menstrual period in 0 there, years before on the left and years after on the right. And what you can see is that the biggest changes in hormone levels occur in the 2 years either side of the final menstrual period, with estrogen declining to a stable new low and FSH or follicle stimulating hormone increasing quite rapidly to a stable new high. There's also this interesting squiggly bit of estrogen before that, which is when menstrual cycles are still happening, but there's a bigger variation in estrogen levels than in premenopausal cycles, up to two or threefold higher variation. But there is a lot of different trajectories for different people. Everyone's an individual, and that particularly applies in the menopause. So on average, the perimenopause, the time from menstrual irregularity up to 1 year after the final menstrual period, on average, that's about 4 years, but for some people it can be much longer, 2 or 3 times longer than that. So what this slide is highlighting is on the right, I've just kind of put the headlines from this recent review. That around 1 in 2 women have clinically significant levels of depressive symptoms or anxiety, also cognitive symptoms or brain fog and sleep disturbance. And then what this chart on the left is showing is similar to that hormone chart. You've got years around the final menstrual period, with it being 0 in the middle, years pre and post along the x-axis. There's a few interesting things about this chart. So it shows that the different mental health symptoms or different menopausal symptoms, which include mental health symptoms, have different patterns. So cognitive symptoms in purple are relatively early, most likely maybe the year before the final menstrual period, and then improve. Whereas depressive symptoms in yellow are most common around the time of the final menstrual period, and then improve. Hot flushes, night sweats, technically called vasomotor symptoms in the orange line, are most likely to occur after the final menstrual period, and then for most people improve. And there's a good news story here in that, with the exception of sexual and genital urinary symptoms, the majority of menopausal symptoms do improve after the final menstrual period. So it's a rocky transition, but then things get better on the other side. These mental health symptoms really matter to people. So this is a recent survey done in the UK, where over 7,000 women were asked, for you, what is the single most important symptom of menopause? And they were given these 5 options in pink here: brain fog, low mood, fatigue, aches and pains, and weight gain. And you can see that the mental health ones, the brain fog and the low mood, are definitely the highest priority symptoms for the women answering this survey. I'd flag that the researchers were interested in symptoms beyond hot flushes, so they specifically didn't ask about those. And for many, they are also problematic and interact with mental health symptoms. House of Commons have also taken an interest, particularly about how menopause influences ability to work. So they did their own survey of over 2,000 women in the UK, who were asked in what way menopause symptoms have affected your ability to work. And of the people who completed this survey, a third of people had to take time off work because of their symptoms. And again, it was the mental health ones of feeling less able to concentrate in particular, and more stressed, that were affecting in the region of 70% upwards of women. I would highlight that these are surveys, so the people who fill out surveys are more likely than most to have the symptoms being asked about. But it's definitely the case that these symptoms, as well as being distressing, can be impactful in terms of how women are able to live their lives and work. And a recent report trying to quantify what that would mean in monetary terms concluded that the UK loses £1.5 billion every year because of time off work or reduced productivity due to perimenopause and menopause. So I'm sorry, I'm having a custom animation issue here. I think I sent the wrong slide version. But anyway, here we are. So what we've got here are that I'm now going to focus on the three main areas of mental health symptoms: depression, anxiety, cognition, and sleep, in a wee bit more detail. So this is again from a recent review finding that on average, women in the perimenopause are 4 times more likely to experience clinically significant depressive symptoms than in the premenopause. And that's particularly the case if you have a history of depression. If you have a history of having a depressive episode in the past, you're about 2.67 times or threefold times more likely to have a recurrence during the perimenopause than at other times of life. And if you've never had depression, you're also at about a 30% increased risk or a 1.3-fold increased risk of having your first ever depressive episode during the perimenopause compared to the premenopause. There's an emerging concept amongst psychiatrists and other doctors that there could be something a little bit different about depression that arises during the perimenopause as compared to other times. In particular, that we usually think of depression as being a really stably low mood of just feeling terrible for at least 2 weeks. Around the perimenopause, there's more of a fluctuating component to it, that being on and off, fine sometimes, terrible an hour later. And also that anxiety is very likely to be prominent, and cognitive challenges are also likely to be prominent. Another emerging concept for you is that there are probably some women who are particularly sensitive to experiencing mood symptoms at times of hormonal flux. For example, premenstrually, before a period, or postpartum, after childbirth, as well as perimenopause. And when largely survey studies have been conducted asking people to look back and report as to what life stages they've had symptoms for depression and for another more serious mood disorder, bipolar disorder, they've been able to find correlations with if you're somebody, for example, who's had PMDD, you're more likely to have a postpartum depression, and if you're someone who's had a postpartum mood episode, you're more likely to have a perimenopausal mood episode. So now I'm going to do a bit of a deep dive on cognition. I'm going to start with objective cognition, by which I mean cognition that we can test in some way, with a piece of paper or a set of questions asked by a healthcare professional. So there were 2 longitudinal studies following people over time, which are the best design of study if you're trying to look at the impact of menopause. And I thought I'd just show you this one, which was from the States, with 400 women followed over 14 years. And I gave them a range of different cognitive tests to do. And the one that they found to be most affected was verbal learning and memory. So that's being able to remember words and names. And the way they tested it was to give people a list of 16 words and then take it away and say immediately, how many can you remember? Which is quite a tough test. And then make it even harder by waiting 20 minutes and asking them again, how many more can you remember? And they've plotted here people who are premenopause, late pre, early peri, late peri, and post. And they've adjusted for age, because of course age affects things like memory too. And they can see that this ability to remember lists of words seems to be sensitive to menopause stage, getting worse perimenopausally and postmenopause for the immediate, but actually showing a wee bit of improvement for the recall after 20 minutes. And I also wanted to flag that although this, looks a bit scary potentially, what it actually is measuring is about half a word less at the worst. So that's still not a big impact. And actually, the majority of objective cognitive tests that were done, there wasn't an effective menopause stage. So it's, again, kind of a good news story that looking, if you do an actual test of cognition, menopause isn't having a huge impact. It's definitely not causing you dementia level effects of cognitive change. But it's definitely doing something. And I also wondered, is it just that these tests are maybe not assessing the right thing? as to what people experience. And other groups have wondered about this too. So this is a group in Australia who try to get more to like what is it that people mean by brain fog, because it gets used to cover a lot of stuff. And they used an everyday memory concern questionnaire. So just asking someone how often they've experienced something like starting to read a magazine article and realizing that you've already read it before. There's quite a lot of data on this slide, but what I've highlighted in red are the key bits, and these are the experiences that were different for the perimenopausal women versus the pre and the post. So it particularly seemed to be being able to remember things. So having to check whether you've done something that you should have done, forgetting when it was that something happened, forgetting that you're told something already, and that tip of the tongue word feeling. So all of those people who were perimenopausal reported as being more likely to be problems for them than people who were pre or post. And that's another positive thing in that these total scores at the bottom, you can see that the higher the score and the more problems, it's the women who are perimenopausal who are having the most problems, and things got back down actually to slightly better than pre for the postmenopausal women. And then a little bit about sleep. So a couple of things to say about sleep problems. These are very common for most people, particularly women, throughout the life, even before you get to menopause. And also, aging has a big effect on sleep. The older people get, the less sleep they need, and the earlier they tend to wake up. But this, I thought, was the best data on the effect of menopause specifically. So this is another study following people up over time, 7 years in this case, of over 4,000 women in the States, with the proportion of people having problems on the y-axis, pre, early peri, late peri, post, and surgery as the categories on the x-axis. So I think what this flags is that staying asleep is the one which has the biggest change at menopause stage, going from about 20% of people having trouble with that premenopausally up to about 40% in the late perimenopause. I mean, that kind of plateaus off. So most of the sleep doesn't get that much better in contrast to some of the other symptoms. This group also looked at hormone levels, and they interestingly found that low estrogen was associated with difficulty staying asleep, but also high follicle stimulating hormone, independent of estrogen. So we often have quite a sex hormone focused view as to what's going on in menopause, but other reproductive hormones change too and may also matter. And this group also identified that hot flushes were really strongly associated with sleep problems. So if you had a hot flush every second day or more, your likelihood of having sleep difficulties was increased 5-fold. And then, not from this study, but from subsequent work, there's also the fact that experiencing adversity and trauma in childhood and adulthood is independently associated with sleep disturbance of its own accord throughout the lifetime, but also interestingly seems to impact people's experience of the menopause, with increasing risk of having hot flushes and menopausal sleep disturbance if you have a trauma background. Again, flagging that it's not all just hormones. The biology and people's life experiences interact together. So I'm a psychiatrist, so I wanted to flag severe mental illness, by which I mean bipolar disorder, schizophrenia, severe depression, which affects at least 3% of women. So this is a kind of another area which is getting more research done. It seems likely that people who already have a severe mental illness are more likely to relapse around the menopause. And it's also the case that if you don't have a severe mental illness, you're more likely to develop one around the menopause, particularly bipolar disorder. But again, good news is that's overall still very rare. A study looking recently found that fewer than 1% of people had a new onset severe mental illness in the perimenopause. The kind of things you might want to watch out for there are feeling suicidal, paranoia, feeling people are out to get you or watching you, hearing voices or seeing things, or really behaving differently to normal. And if that's something you worry about for yourself or someone else, then you can get help from GP, NHS 111, or if it's an emergency, A&E. Okay, so I'm going to start talking about biology quite soon, but before I get there, I just wanted to flag again that it's a melting pot of societal pressures and psychological stresses and all the things that shape how our mental health is day to day. And I really liked this figure from a recent study in Australia, where they term it the midlife collision, of kind of all the things which make midlife challenging, caregiving for aging parents, young children, financial pressures, which are often worse for women, more likely to be working less full time, less likely to have stable jobs. These things intersect with the biological challenge that menopause is bringing, to make it, for some, quite problematic. Okay, but now I'm going to talk about some biology. So this picture of our brain is really just a flag that, although we think about sex hormones, estrogen, progesterone affecting ovaries and wombs, they affect lots of bits of your body, including your brain. And these are some of the brain regions that have estrogen receptors. And these are important brain regions that are known to be involved in how we think, feel, and behave. Very complex diagram here, but the key bits are the green boxes are what estrogen does, and the orange what progesterone does. And you can see that a whole range of neurotransmitter systems are regulated by sex hormones: serotonin, dopamine, GABA, which is for inhibition, and glutamate, which is for excitatory communication, your standard communication between neurons. And it's not quite as simple as some go up and some go down. Sometimes it's region dependent. Sometimes progesterone does it one way and estrogen overlaps to an extent but does a few other things. Taking another step back, it's not just neurotransmitters. Sex hormones also regulate inflammation and metabolism, how we get our fuel from food and store it. And these systems also impact brain function. And as I flagged follicle stimulating hormone already, it also has receptors throughout the brain, and what they do is under investigation. So this study I really like. It's a trailblazing study done in the States with almost 200 women, which for brain imaging is a really big study. And they looked at people who were pre, peri, and post, a whole range of brain parameters, and I've just picked a few of them: grey matter volume, glucose uptake, and blood flow. And you can see that plotted in these bar charts, pre, peri, and post, how these parameters change. And again, the take homes here are that some things go down during perimenopause and then up postmenopausally, kind of back to more like they were pre. Some things like the glucose, it's more of a change that then remains steady postmenopausally. And I also wanted to flag that it's often tempting, when we see something go down or it's different, to feel that that's like an impairment, but that isn't necessarily the case. I think we also know that grey matter volume reduces during pregnancy, for example, and that's thought to be an adaptive response to help new mothers be able to really focus on caregiving. I think probably something similar is going on with the menopause. The brain is being optimized for a new way of being, which doesn't involve having new babies to look after. And this is looking at estrogen receptor density again. So like that previous slide I showed you, you can see all the blue bits are very low estrogen receptors, and the greeny orangey bits are more. The more orange, the more receptors. So lots of green and orange in the premenopausal people, and even more in the postmenopausal. So actually, perhaps counterintuitively, your number of estrogen receptors in your brain goes up postmenopausally. Reasons unclear, but perhaps it's to do with making the most of what estrogen is still circulating. And this group also plotted the number of estrogen receptors in all these different brain regions against people's experience of menopausal symptoms. And the dark blue ones are ones which seem to be strongly correlated. So you can see that reporting mood challenges during the menopause was associated with having more estrogen receptors. So that does implicate the estrogen system in that experience. So I'm getting towards the end. I'm sorry, I'm running a little bit over time here. These were just some of my things. I just wanted to flag that a lot more work needs done here. I'm sure you're aware this is a historically neglected area, and these are some of the things that I thought would be good to investigate further. I'm sure you'll have your own ideas too. And now to move to my summary, which is really that the menopause is a time of challenge for mental health, but things do get better on the other side. It's an intersection between psychosocial challenge and biological change. Sex hormones and other reproductive hormones regulate multiple neurotransmitter systems and brain regions. But menopause is associated with changes in brain structure and function, undergoing a kind of system upgrade, but much more work is needed to understand more about this brain update and how that relates with symptoms and how to optimize things for people in whom it's a bit of a rocky transition. Okay, I think that was me. Thank you for your attention, and I'll hand over to Becky.
Thanks very much, Katie. And just to say before Becky comes in, that was just incredibly interesting, and lots of information there. And for those of us that are lay people, quite a lot to take in, but hugely interesting. And I saw people in the chat coming in and saying how helpful and interesting that had been. So let's hear from Becky, and then we'll go into the Q&A. Becky, over to you. Oh, just before I hand over to you, let me just say a few words about who you are. You're a GP and a GP appraiser located in Lanarkshire. You're certified, and this is so hugely interesting, I think, in lifestyle medicine, and you adopt that holistic, person-centred approach to healthcare, emphasising the significance of lifestyle modifications in conjunction with medical treatments to enhance health and well-being. And you're trained also as a transformational coach. I think that's going to be incredibly interesting to people listening today. So thank you so much for joining us, and over to you to talk a little bit about understanding how menopause might impact on mental health and well-being. Thank you.
Thanks very much, and hopefully my slides are about to appear. So Dr. Katie, that was amazing. I think what that really helps us all realise, and we know this already, because if you know a woman, we are incredibly complicated. We're not straightforward. So anybody in the wellness world that says absolutes about treatment or management, don't listen to them. We are complex beings, and often we have to try different things to see what's going to work for us as an individual. So yeah, lifestyle medicine is something I'm really passionate about. It's the science behind how we live and the impact that that has on our health. And so what I'm hoping to bring to you today is a little bit of an overlook of things that we can do. Kate has told us what goes, I'm not going to say goes wrong, what changes in our bodies in menopause. So how can we empower ourselves to manage and to cope with that? So next slide, please. This is just an overview of what I'm going to look at today. We cannot talk about menopause without talking about HRT, or hormone replacement therapy. So I'm going to touch on that. I'm going to talk about lifestyle change and healthy habits. And again, these are rooted in science. These are not some gummy that you're going to buy off Instagram or TikTok shop. This is about sustainable changes that are going to help and improve your health. And then also about talking therapies and CBT as well. So we'll pop onto the next slide. HRT. So we've heard a lot through the first presentation there that a lot of our issues are down to the lower levels of estrogen. We've also heard about FSH as well, which is the hormone that tells our ovaries to do what they've been doing for years. But if we think about estrogen, effectively HRT is about replacing that missing hormone. And we know that it's not just about estrogen, that other hormones do matter as well. So progesterone is important, and in some respects, we think of progesterone as being the sort of calming, sort of sedating type of hormone. So that can sometimes help sleep. And then what has become a hot topic is testosterone for women. We used to think of this as the male hormone, but actually women produce a lot of testosterone throughout their reproductive life. It's a very important hormone. And we often think about it from a sex hormone perspective for libido. but there is growing evidence, and we don't quite have the scientific evidence yet, but anecdotally, a lot of people that add testosterone to their HRT do start to say that they have some mood improvement and some cognitive improvement as well. So once again, as Katie so beautifully demonstrated, hormones go up and down. There's a big variation in things, but from a very simple perspective, if you are missing hormones because you've gone through a hormonal transition, then replacing them with HRT can have a big impact on how you feel. So a lot of women will say that it's improved their sleep and their energy levels, and sometimes just describe feeling more like themselves again. Now, I also appreciate not everyone can take HRT for other health reasons, or they maybe don't want to, and that's absolutely fine. So yes, HRT is important and women should have easy access to it, and we need to do a good job of ensuring that people can access HRT, but there are other things that we can do as well. So let's move on to the next slide. Physical activity. Now, before everybody groans, I'm very careful to talk about physical activity as opposed to exercise. I think sometimes exercise conjures up this idea of sweat and lycra and uncomfortable gyms and places where you feel out of place. And if your mood is low, the thought of trying to go and do an exercise class or do something that takes a lot of work can be totally overwhelming. So this is about just trying to start to do some more movement. Now, I think everybody will have heard of endorphins, these kind of feel-good chemical transmitters, and we know that physical activity increases endorphin release. And so movement, and particularly movement outside, is so, so powerful. Being outside is useful because we know that being in nature can help lift people's mood as well. And plus, we're about to enter winter time in Scotland, where we kind of have clocks have just changed. So we have a lot less daylight. And if you can get outside in the daylight, this has a good impact on health as well. So even just thinking about things like vitamin D levels and other health parameters, being outside, doing physical activity outside is ideal. Now, when I say the aim is for 150 minutes a week, the idea of that is all the guidelines around about longevity, lifespan, health would suggest that we should be aiming for about 150 minutes of physical activity a week. And that's moderate physical activity. So we're thinking about maybe walking at a pace where you can just about hold a conversation, but if you tried to sing, you'd be far too out of breath. And actually 150 minutes equates to about 5 30-minute walks a week. And that doesn't always need to be done at the same time. So a 15-minute walk in the morning, a 15-minute in the afternoon can have a big impact on our physical health and our mental health. Again, if you're not doing anything at the moment, I'm not saying suddenly that you need to go to 150 minutes next week. Building it up, slowly getting into the habit is far more important than making yourself feel overwhelmed, not hitting your target and then not doing anything. So that's not what we want to have happen. Now, I've added in bold there strength training, and the reason that I add that is because this is more from a physical perspective, but it does have a knock-on effect with mental health. We know that when women go through menopause, there are issues then with bone health, with muscle strength, sarcopenia, which is a loss of muscle starts to set in. So trying to build strength training into and resistance training into the type of exercise you do is very, very important. And the thing about strength training, and I think with mental health, is that often if you've been somebody who's been physically active throughout their life, say you were a runner and you hit menopause, you might find you're not as fast as you used to be, you can't run as long as you used to be. But strength training is something that people find they can actually hit improvement in and see improvement in quite quickly. And that's very powerful when everything in your life feels like it's in chaos. To have a kind of structured approach to lifting weights, to finding that you can lift heavier weights than you used to be able to lift, can have a big impact on mental health, because suddenly there's something that feels like it's going well for you and that you're seeing improvements in. So that's why I like to put in how important strength training is. And then across lots and lots of trials, we know that it can improve depression and anxiety. So physical activity, absolutely something really important to start to build in. Next slide, please. So nutrition, there are some large meta-analysis, which are studies that look at other studies, if you like, that have found that high consumption of junk food and ultra processed food was significantly associated with increased risk of depression and anxiety. So what does that mean is that where there is an association with people who have mood and anxiety issues and higher levels of poorer dietary choices. So when we talk about junk food, we're talking about fast food, lots of sugary foods. You've probably all heard about ultra processed foods now. There's a lot in the media about them, but this idea of food that isn't really real food, it's made in factories, it's made to be incredibly delicious, it's made to keep you wanting to eat it. But when you look at the ingredients on a packet, it's absolutely full of ingredients you wouldn't find in your kitchen. So we're still trying to work out cause and effect between this kind of way of eating and mental health. We don't know whether people get low and depressed and then they seek out more unhealthy foods because they're looking for dopamine and they're looking for improvements in that. So we don't know if it's that, or we don't know whether it's more that the actual foods themselves cause a low mood. But either way, there's a big correlation between the two. So the type of nutrition we need to move towards is we need to be looking at eating real food, food as it is in nature, high levels of plant-based food, so fruits, veg, beans, pulses, lean proteins. And we sometimes describe that as a Mediterranean style of diet, but it really is just that going back to what nature produces and eating that way instead of the kind of ultra processed eating. And it's important to add in here that alcohol is a depressant. A lot of people do start to drink more around about menopause because they think it helps their sleep, or they feel quite overwhelmed, or they feel anxious in social engagements, so they tend to drink more. But it does have a depressant effect on the body, so it is really, really important to try and reduce alcohol. Move on to the next slide, please. Now, here we go, social media. Now, there are some brilliant things about social media. The very fact you're on this call is probably because somewhere in all the social media marketing, you've heard about it. But there are also a lot of negative impacts to social media as well. So if we understand how social media works, there are to keep you online is how social media companies make their money. So the more time you spend online with your eyes on the screen, the more advertising space that they can sell. So they're very clever. They create algorithms to keep you online, to keep you scrolling, and they work out exactly what keeps you online. So you might find that your news feed is completely different to somebody else's. So some people's are full of cute puppies. Some people are full of babies doing cute things. Some people's are full of very negative imaging, maybe self-harm, maybe other things that can be quite problematic. And so if we end up with our algorithms full of the same sort of information, that can have quite an impact on our brains. So not only is it set up to keep you there, we know that negative news stories tend to sell. They tend to keep you online with the clickbait that happens. People are more likely to click on negative news stories. So you're filling your mind with negative thinking the more time you spend on social media. I love this phrase that comparison is a thief of joy. And I think we spend a lot of time on social media comparing ourselves to others. We see it with teenagers. We see the harm that that has on our young people. If you've ever been a new mum and been online and seen these mums that seem to have it all, their kids are well dressed, they look beautiful, they've not got vomit on them and their hair's not bedraggled. We can start to compare ourselves with unrealistic, untrue images, and that has a big impact on mental health as well. So I think social media has a place where it can be positive, but I think we do need to maybe start to limit the amount that we're using. And if our mental health is not in a good place, definitely coming off social media and very much taking your phone out of your bedroom so you're not scrolling in the middle of the night when you can't sleep. So reducing social media use will have a better impact on mental health. Move on to the next slide, please. This is a really simple activity that people can do that has been shown in research to improve mental health. So this is using the sort of positive psychology model for improving mental health. And it's this idea that by spending a bit of time every day thinking about 3 things that you're grateful for, it can have a big impact on your mind. Now, I like the idea of actually pen to paper doing it, and it might be a good excuse to buy yourself a nice pen and a nice notebook to do this. But even if you haven't got the energy, you're feeling overwhelmed to try and write it down every day, even just as you get into bed at night, try to say to yourself, what are 3 things that I'm grateful for? And it starts to change how your mind works. So really simple things. It could be, I was really grateful for that webinar I went to today. I was really grateful that so-and-so made me a cup of tea when I was feeling a bit stressed. It doesn't need to be big things. It can be just looking at each day and reflecting on what's gone well. And part of the reason this seems to work is that your brain can't hold negative and positive thoughts at the same time. So if you're actively trying to put positive thinking into your brain, it does take the space away from those negative thoughts, and it can be quite a powerful strategy. And the research shows that the effects of doing this actually last longer than the intervention. Obviously, the longer you do it for, the better, but let's suppose you do it for a week, the actual positive effect can last longer a week. So it's a very useful strategy, very simple strategy. It's completely free unless you spend a lot of money on your pen and your notebook, but it can be a really helpful thing to do to try and start shifting the way that your brain is thinking. We'll move on to the next slide, please. I'm sure we all sadly can still remember the pandemic far too well. And I think what that taught us is just how much human connection is so important for people. When we were isolated, a lot of people became very lonely. We can probably all think of friends and family, particularly elderly friends and family, who before the pandemic were out and about, maybe going to coffee mornings, maybe doing sports classes. The pandemic hit, they became isolated, and they've never quite been the same again. And that's both physically and mentally, because we need to be connected to each other. It's really important for our well-being. Have you been in a restaurant and looked around you at families that are sitting with their phones out? They're physically present with each other, but they're completely mentally distant. So the other important thing is it's not just about connecting with people and physically being in a room. It's about putting away your devices and talking to each other. And that's within friendships, that's within families as well. I've mentioned healthy relationships. Sadly, a lot of women end up in quite toxic friendships, quite toxic relationships. And this only really works where the relationship is a healthy relationship, where there's mutual respect, mutual love and kindness. And we know that social connection and community works because it activates oxytocin, which is a feel-good hormone, the sort of love hormone. It's released when we hug each other as well. And it activates the parasympathetic nervous system, which helps to calm us down. The other amazing thing about social connection is it actually can help encourage health behaviours. So you're far more likely to be able to adopt and maintain a health behaviour if you do it alongside other people and do it in community. So again, trying to find connection with people, groups. There's things like the Menopause Cafe can be really powerful in helping with this. And there's other organisations locally as well that you can engage with just to give you that social connection and that community. It's very important that you realise that you're not on your own in how you're feeling, and hopefully listening to this whole webinar makes you realise that it's not just you, you've not gone crazy, that this actually is because of the chemical changes and the hormone changes that you're experiencing. We'll move on to the next slide, please. So there's good research as well that a type of mindfulness called mindfulness-based stress reduction can be really helpful as well. And there's a number of organizations that run this kind of therapy, but it's similar. Mindfulness is this idea that you take note of where you are in the present without judgment, without assessing it. You just start to notice what's going on both around you and inside your body. There are obviously practices that build mindfulness in, so things like yoga, breath work, Tai Chi. But the thing about stress management is that it varies from person to person what works. I know of women that go and do cold water swimming, again in a community, and that can have a lot of power to it as well. But it's this idea about purposefully trying to adopt a different way of thinking. And that brings us into the sort of CBT approach. So CBT stands for cognitive behavioral therapy. And if we move on to the next slide, the idea of cognitive behavioral therapy is to look at our thought patterns, processes, and to examine the way that we think. So it's about reframing our thoughts, that sometimes your thoughts are wrong. And I know sometimes that's hard to admit that we're wrong, but sometimes our thinking patterns are actually flawed and they're not true thoughts. And the idea of CBT is to learn how to examine our thinking patterns, to challenge our thoughts, and maybe to change our thinking as well. And there's good evidence that CBT has been shown in trials to improve the symptoms of hot flushes, of sleep, of mood, and of quality of life. And it's most likely that it works by changing how women think and feel about the symptoms rather than it necessarily stopping the hot flushes. It makes the hot flushes more bearable, and that women's thinking around the hot flushes starts to change as well. I suppose it's a bit like when we were looking at the cognitive decline that comes with menopause, that actually when we test for cognitive issues, they're not as objectively problematic as they might feel. And some of the problems with the menopause symptoms is that when we allow our brains to become overwhelmed by them and to panic about them and to worry about them, they start to take on a kind of trajectory of their own. So by challenging our thinking around the symptoms, that can actually help the symptoms as well. We'll move on to the next slide. So I think the key thing here is that if you are in a place where your mental health isn't great, I'm not asking you to do all of this at once. It's about changing one thing at a time, and that small changes make a big difference. And then just building on having a small win, something you know you can achieve, and then stacking on top of that habit with another habit that's going to improve things. So choose an easy win, choose something that feels doable, get on the phone to a friend and say, look, can we hold each other accountable? Could we go for a walk? You know, it's getting a bit darker. Can we maybe do a morning walk? Or, you know, and trying to think about a strategy that's going to work for you rather than trying to do it all at once. I love this idea that a year from now, you'd wish you'd started today. So just start something, just make that first movement towards some of these changes, and hopefully you'll see an improvement in your mental health as you do. And I think that is my last slide.
Thanks very much, Becky. Again, you know, a hugely comprehensive presentation with lots of practical information as well. I mean, I was absolutely blown away by some of the information there. I did know a little bit about the gratitude journaling, but I didn't realise that contradiction between positive and negative thoughts at the same time. So I found that hugely interesting. Okay, I think what we're going to do now is try to get to some of the Q&A. And there's been quite a lot of conversation, and I think you answered a little bit of it, Katie, around testosterone. There's been a lot in the chat around that as well. I've not been able to fully monitor the chat, but there were questions and quite a bit in the chat with different views around testosterone, who can prescribe it, when it should be prescribed, can the GPs do it, and so on. Is there anything either of you would want to just very briefly say on that? Because I know you put something in the chat as well, Katie.
Oh, yeah, so yeah, testosterone, emotive topic, unclear what is best to do. It declines gradually with age. There isn't a big before and after menopause effect. It's just a gradual decline. It does get converted to estrogen though, so you can see how it still be relevant in that way too. The key thing with testosterone is that there just isn't evidence to support its use beyond libido. There's definitely people's lived experience that it can help with mood and cognition, but not everyone finds that. And it's just really important in medicine that we do things based on what evidence shows us. And the good news is that there are efforts underway to improve the evidence base there, with, for example, a randomized controlled trial, the highest level of evidence possible in medicine, underway in Cardiff, looking at symptoms that might benefit from testosterone beyond libido. So this is an area to kind of watch this space, and probably we'll have different guidelines in 10 years, but you know, we are where we are right now.
Yeah, and I totally second that. It is so difficult. And I think, again, it's great that women are talking about it, but I think we've got to be so careful not to draw conclusions that are not there yet. And interestingly, in some of the research that has been done, there is a high placebo effect as well. So it's that idea that if you're using something you think will improve things, it may well improve things. So to jump into the question about why aren't GPs prescribing it? So I think as a GP, I feel okay to answer that one. So it's a newish within the last 5-6 years query that's been coming up time and time again. And strictly speaking, is meant to be specialist initiation. So a lot of GPs would say, I have no training in this. I don't think it's safe for me to prescribe it. The BNF says specialist initiation, and so I'm going to have to refer you on to a menopause clinic. But we don't have the structure within the NHS to cope with the numbers. So what is slowly changing is that GPs are developing more of an interest in it, more of an understanding. Health boards are feeding back to GPs saying, following the correct guidelines, and the British Menopause Society have really good guidance that actually, yes, you can start to prescribe it, but it does need to be monitored with blood monitoring. We do need to make sure we're keeping women within the what's called the physiological range of testosterone. So you do need to be monitored to make sure that we don't overshoot, because if we overshoot, we'll start to cause potential masculinization type symptoms. And I think, again, at this age and stage, we are so overwhelmed with all of what midlife throws at us that if you read something that people are saying this is going to make all the difference to you, you're going to be absolutely desperate to get a hold of it. And then when I prescribe it to women, I often find they're disappointed by the results. They've expected it to be this kind of magical potion that's going to make everything else better. And I suppose that's the same with HRT. It is great, it has a big impact, but we have to do all of the things we've talked about today. It's not just about hormones, because if it was just about hormones, then every 25-year-old woman would be fine, and they're not. So we need to look at the way we're living as well, and we have to think about that whole piece of who we are within our modern society, with the pressures that we're under, balancing all of the different responsibilities that midlife brings to you. So yeah, that's the issue with access to testosterone. But hopefully that helps.
Okay. Thank you. I think it's helpful to have that context and narrative. I'm going to try and sum up a few of the questions here. There are a few of them that are talking about HRT generally. One is around, are there some women that this just really doesn't help? For some women, does it cause depression? One woman's feeling that it causes her depression. And then there's a question around, despite the nice guidance, from Caroline, women have to exhaust psychotropic medication before being treated with HRT. Is that widely the case? And should it be the case? So a few there just around HRT. I wonder if both of you would like to have a shot at dealing with some of that.
Katie, do you want to go first with the psychotropic side of things? I mean, from a GP perspective, we've been getting it wrong for a long time. Like, I'll just be honest, we haven't thought, could this be hormones? But I do think that messaging is changing. But I think maybe Katie can take it from a psychiatry perspective for us.
Yeah, it's very interesting, actually. If you go back to the 19th century, psychiatrists talked a lot about the menopause. And then I think it maybe went a bit too far, and it got used against women to suggest that they're inferior, hormonal, fragile, unpredictable. And I think it's maybe the pendulum swung too far towards ignoring hormones and just thinking about psychiatric medication. But definitely my experience with my colleagues is that they're really interested and they want to incorporate thinking about hormones as another tool in their toolkit to help people's mental health.
And I noticed there are another couple just before you come in, Becky, about HRT and the impact on chronic health conditions and the difference between body identical and bio-identical HRT. That's quite a specialist one, but I don't know if there's anything in those areas you would want to comment on.
Yeah, so sometimes the terminology gets a bit confusing. So body identical, bio-identical are kind of interchangeable quite often. And what we're talking about there is that they are based on the same hormones that we actually produce. For a long time, we used synthetic hormones in the older HRTs, so more of the oral HRTs are synthetic hormones, whereas the transdermal, the stuff that we use through the skin, tends to be more body identical, so it matches what our bodies have produced. There is still a place for some of the oral HRTs, so where the transdermal haven't worked for people, there's still a place for them, so it's not an absolute no-no with them. There are companies that are selling what's called compounded body, now let me get this right, bioidentical. So there's pharmacies that are producing, they take a sample from you and they then allegedly match to what you need. But British Menopause Society, most doctors would say to avoid that way of prescribing because it's not regulated like the prescriptions are. So I wonder if that question was kind of touching on the compounded stuff that's out there in some of the chemists. It's difficult to know. But yeah, so what we try to prescribe now is similar to what our bodies produce rather than the synthetic hormones. But for some people, the synthetic, they just don't get the results that they need through the skin, and then we need to use the synthetic oral hormones. But HRT, there's a lot more interest from drug companies in making new products because suddenly people are buying them. And sadly, we live in a world where money talks. So with the demand going up for HRT, we'll find new products start to be produced as well that are going to maybe be more suitable for women as well. So in many respects, it's a really positive time that we're starting to see change. But for some women that are going through that change right now, we just don't have that information. We don't have those products readily available. And unfortunately, it'll be the next generation that will benefit rather than us. But we've got to be positive about the movement that is starting to happen.
Thanks very much, both. And then there's one about hair loss and some of the symptoms. Again, it's around depression, but someone here who's 33, and is there anything that might impact on hair loss? And I suppose it's the confidence around that. And there is another question that's a little bit related, and that is, someone asking how we get better recognition of menopause symptoms, because as an employee, she actually lost her job. And it was just that, people didn't recognize the brain fog that she was experiencing, the forgetfulness. And she actually feels a little bit discriminated against. And I suppose the question is more generally, it's good that we are talking more. And a lot of people have been saying that in the chat, and it's great that we're having this openness and discussion. But are we doing enough? And when ladies asking about, should this be a protected characteristic? Should there be some sort of additional recognition, particularly in relation to employment issues?
So, Katie, do you have anything there, or do you?
Well, I guess a general principle it's really something for policymakers, but I think it's quite interesting when we think about like women's health specific policies, like for should we have menstrual leave, should we have menopause leave, those kind of things. They can be very positive and well intentioned, but actually when other countries have had menstrual leave for quite a long time and it doesn't work that well, and it seems to increase discrimination against women. And what's wrong with just using normal sick leave is the idea there. If you're having problems with your cognition, then that's a problem, whether that's due to menopause or anything else. So that's the devil's advocate role position for that.
I'll just add there is movement within employment law for menopause in the workplaces. So it's not necessarily going to be law, but there are suggestions that employers need to take consideration for this. And I do think we're going to see more of that coming in. And as you mentioned, you could potentially use some of the discrimination issues around about age, because menopause happens at a certain age, that this could come under age discrimination. So I think get legal advice if you are having problems from your employer. I would definitely say it's worth, because there is movement in this area. Again, policy takes time to come in, but there is various acts, and I was just having a quick Google. The Employment Rights Bill is expected to bring some mandatory menopause parts to it as well. So I am aware that things are moving in this area, but I think Katie made a really good point there. We don't want to make things so difficult to employ women that we no longer get employed in the first place. And that would still be discrimination. But I'm sure lots of women have sat here knowing that they didn't get a job because they were of childbearing age, whereas it shouldn't happen, but it does still happen. So we've got to make sure we do it well, and but keeping women in the workplace is vital.
I think things that help women help everyone. We should be taking a flexible and compassionate approach to men who also have fluctuating health challenges.
Yes, I think that, very good points, and some of it I think, is about having that confidence to sort of recognize that you are being discriminated against a bit, and I think peer support groups and also like these conversations that we're having just now that, you know, open things up and make things more transparent, and you know, the sharing of experiences, so that you know and understand you're not alone in this journey, and having professionals understand and support, you know, some of the symptoms that you're experiencing. So we've got quite a few other questions, and I was just going to say it's really helpful if you could keep the questions short, because sometimes they're so long it's hard to get to the actual issue. But just picking up on a couple, there was something around menopause and neurodiversity, particularly ADHD. Is that something for yourself, Katie?
Another very topical question, and it seems very plausible from the biology that ADHD symptoms could get worse. You know, that one of the neurotransmitter symptoms regulated by estrogen is dopamine, and certainly, you know, I've met people who feel that their ADHD gets worse around menopause, and in the PMS clinic we do seem a kind of more reproductive hormone sensitivity in people with ADHD. There's not been a lot of evidence, and I put in the Q&A, actually, I was looking for that this morning. The biggest and best evidence I could find from this year of over 200 women with ADHD compared with 400 women without pre, peri, post menopause symptoms. Actually, there didn't seem to be an association between ADHD diagnosis and menopause symptoms on or off. So I think this is just, it's an emerging area. It's not clear yet what the nature or strength of association is.
There's a very good question in the chat about how long do we stay on HRT, and how do we know when we don't really need it anymore, and how do we know that our bodies are actually adjusting to the new norm if we keep taking the HRT? Is it about reducing gradually, or, you know, is there guidance around that? And that's from Lynn.
So the first thing I would say is you can take it for as long as you feel you need to take it. So we don't set time limits on it. Every woman is an individual. It depends what's going on in your life at the time that you might be considering coming off it. If you're in the middle of a very stressful time, it's maybe not a good time to come off it. I think a sensible approach, and it will vary from woman to woman, is to think about starting by reducing it. But there's no hard and fast rules. You could just stop it and see what happens. But I think you're probably going to find, even if it's more of a psychological effect, I think you'd be better to slowly reduce it down rather than just suddenly stop it. But it's a discussion to have with your healthcare professional, weighing up the pros and cons for you as an individual. Your body would need to adjust to the new normal as well. So, you know, you need to give yourself time before you suddenly, you know, your body's been used to having HRT, so you would need to give it time to get used to not having HRT before you could make an assessment of things. I think too many people are worried as well. It's from the other side of it when people say, well, will it help my perimenopause symptoms? And you can't really answer that without trialing it. So I think sometimes we've got to be more willing to try things. But what I would always say about HRT is it's a marathon, not a sprint. So if you're going to try it, or you're going to try reducing it, you need to give it time before you make a reflection of whether it's worked or not. So, you know, 2 days later, if you don't feel better, that's not been long enough. But yeah, I think it's having that conversation and working out the way that's going to work for you. I'm always keen to make sure women are in the driving seat of the decision making. And so you need to do that with your healthcare provider.
So I guess a kind of related question from Jacqueline about premature ovarian insufficiency resulting in early menopause, and she was diagnosed at 33, and she's on HRT, but wondering about the long-term effects and whether the long-term effects of HRT would be worse than those for POI. But I think in a way, Becky, what you're saying is you can be on this for as long as you need.
Yeah, and I think for POI, definitely take it until you get to the average age of menopause. So from a bone health perspective, it's really, really important that you get to the age that most women would have got to and gone through at what would have been a more normal age for menopause, so early 50s. But you absolutely could take it past that if you wanted to. But it is really important from a other health perspective to take your HRT until that sort of normal menopause age.
Oh, there's a question here. I mean, it's new to me. I'm not really sure about this, but creatine supplementation for perimenopause, including dosages for particular times of the day and in combination with strength training, is that something that you could answer, Becky?
Katie's nodding.
I know a wee bit about this. This is another area that's emerging. So creatine's been used for a long time now to help muscle building, but not just by taking it. You've got to also do some strength training. But if you're doing the strength training and taking it, it slightly increases muscle volume. So that's potentially worth considering around menopause just for that reason. And there are also studies looking at its impacts on cognition. And they've been reviewed together. There's been like 16 relatively small trials, and it does seem like it has some smallish benefits on cognition, particularly in women, particularly in sleep deprivation. But I'm not aware of any trials looking specifically at menopause. So we're not in a place to be able to give like dosing guidelines or time of day. I don't think that data is there yet, but the indications are interesting. Yes.
Yeah. That's what I've kind of gathered so far. I wouldn't even be able to advise a product particularly because, this is a difficulty with supplementation, is that there's such a wide variety of types. And obviously sensible marketing strategies around products would be to tell you that their product's the absolute best. But I wouldn't be in a place to be able to advise in the specifics of it. But there's definitely emerging interesting research there, and creatinine's definitely become one of these things that is being talked about a lot.
So kind of watch this space on that one. And there's also a question about the use of the coil for breakthrough bleeding perimenopausal, and whether there's research and evidence that kind of supports that. So
the idea of the Mirena coil is that for many women for many years, they've ended up needing to have hysterectomies because of heavy bleeding. And the Mirena coil has reduced the amount of big surgeries women are having to have because it does manage bleeding really well. And one of the problems in perimenopause is that heavy bleeding, clots, start to become a big problem for some women. And that's partly because our cycles are not always governed with ovulation. So there's more of a hormone chaos. And so for women that are having flooding, that, I was talking to women at the weekend at a seminar, and there was people talking about the fact that they couldn't go out because if they stood up, they would just flood with blood. Unexpectedly, their cycles were all over the place, so they couldn't predict it was coming. And the Mirena coil has been really, really useful at managing that. But I know a lot of women don't like the idea of it, and so they're put off by it. But the way it works is that the progesterone is within the actual Mirena coil, and it basically stops the buildup of the lining of the womb. So the bleeding, if not stopping altogether, becomes a lot lighter. And the nice thing about the Mirena coil is that we can then use that as part of the HRT as well. So we can use that as the progesterone part of HRT. So we can combat the effect that estrogen might have had in overstimulating the lining of the womb. So it can be used as part of HRT. So it is actually very useful. But again, I know not every woman wants that. So we have to listen to women and listen to what they want. But having a hysterectomy to manage bleeding is a big surgery, and surgery has risks. So we've got to always think about balancing the risks and benefits of anything that we do for a woman. But we do need to explain it properly to women so they can make those decisions for themselves.
Well, thanks very much, everyone. I'm conscious of the time now, and we've had such a rich discussion. And thank you so much, Katie and Becky, for the amazing responses and detailed responses, and the very informative presentations that you've given. It's been very helpful.
For more information, see the links in the description box below.